So the next speaker is Dr. Peter Jones, who has recently taken a part-time role working as a community rheumatologist, one of my brethren, in the Nelson Marlborough district. Trained in the UK, he worked in multidisciplinary team at QE Hospital for Rheumatic Disease and Rehabilitation in Rotorua from 1995 to 2010. During this time, he took on an academic role with Auckland University, developing Rotorua as a teaching campus. He moved to the Waikato Clinical School as a deputy head in 2010. At the national level, he chaired the Specialist Advisory Committee for Rheumatology for RACP, co-authored the Australasian Rheumatology Training Curriculum, developing standards for accreditation of training sites, and initiated supervisor training in rheumatology. In his current post, he is the clinical lead for the Ministry of Health's program for continuous quality improvement through health system integration using system-level measures. He also leads the Mobility Action Program, providing community-based multidisciplinary care for people with musculoskeletal disorders. He'll focus, I believe, on what is meant by these different levels of integrated care. Dr. Jones.
You'll see in my title slide that two of my employment roles contain the word community. Okay, so first of all, integration has become a bit of a buzzword, and it creates a little bit of allergy when you mention it to clinicians. The first point I want to make to you is that there's different levels of integration that people talk about. And probably if you go to integrated care conferences, a lot of what people talk about is clinical integration at the service level, by which we mostly mean multidisciplinary teams. And then there's professional integration, where you might have a service that is organized around a particular disease state or an organ system. And then there's another level, which is a little bit more challenging, and what I've been working at the Ministry of Health, which is about system integration. And so when I came to present the talk today, I've actually I thought I'd produce two talks. One's about service level integration and one about system level integration, and I couldn't decide which one to give, so you're going to hear both. So I was lucky enough in 1995 to arrive at QE Hospital in Rotorua, which is, if you like, a rehabilitation unit for people with musculoskeletal conditions, and we had 10,000 bed days a year before the advent of biologic drugs, which has, and other good treatments, which has perhaps lessened the need. But I worked in a multidisciplinary team, and this was something that I had not been prepared for in my training at all. And my training of 4 years in specialty also didn't prepare me for dealing with about half of my patients who really had needed a chronic care medicine approach. And I learned a number of things from working in a multidisciplinary team. The first was, it didn't have to be led by a doctor. Could be led by a nurse, and indeed it was. I also learned that other people in the multidisciplinary team had a different perspective on health and a different worldview that deeply challenged my conditioning in medicine and the medical model. And I probably learned the most from an occupational therapist, and the second most from a counselor. In my current job, I'm a community rheumatologist in a medium-sized district with a population of 150,000 across two towns, which are separated by a fairly large range of hills, which takes a couple of hours to navigate. And our local district health board, which would be the district in Australia, funds the primary healthcare organization to the tune of 500 new specialist appointments a year and 1,200 follow-ups. So there would probably be 3,000 to 4,000 people in this district with inflammatory arthritis alone. So somewhat underfunded. And so the model that has been produced has been not because we had some idea that this was a great thing to do that was going to improve patient care. It was a solution to a problem. And so it was really about how do you spread a very rare resource, a rheumatologist, as thinly as you can. And so the model really is that I work in a clinic with, I have about 6 GPs with special interest who work in the clinic. There's 2 to 3 of them in the clinic at any one time, plus a specialist nurse. And then I also do some specialist-only clinics with perhaps some of the sicker people. And we have quite a high use of virtual reviews and for first special appointments. And I have to run a very tight triage system. I decline about 50% of the referrals, but I try to give some helpful advice back. We'll just skate over that. So what are the advantages of this model? Well, as I said, it maximizes the use of a limited clinical resource, and it does improve communication between primary care and secondary care healthcare clinicians. And it should be empowering of primary healthcare to take on and manage a lot more of the musculoskeletal health needs of the people in the community, which traditionally perhaps have been done by hospital-based outpatient services. And it also gives us potential to develop a different model of care which is better integrated and patient responsive. But it's not quite working as well as you might expect. And the first thing is that although it's got some advantages, it's basically still a secondary care model. I've just been transplanted out of the hospital and plonked in the community, and instead of being employed by the health board, I'm employed by the primary healthcare organization, but on a very similar contract, you'll be pleased to know. There's limited capacity for primary care to support the model. If over in Blenheim, we pull people out of primary care to work in the rheumatology clinic, this is a town in which there are closed books for patients to actually sign on with a GP, so that isn't terribly helpful. There's also, ironically, rather poorer access for my hospital colleagues to get help from me or an opinion. And one of the challenges for me is to develop this concept of in-reach, coming into the hospital to provide some services. For instance, transition clinics for pediatric rheumatology, or combined clinics with ophthalmologists for people with inflammatory eye disease. There's also a challenge that the management clearly expect that providing services in the community should save them a bunch of money. And there's absolutely no reason to suppose that that should be the case, although hospital services traditionally are viewed as being quite expensive. And as you'll know from my level of funding, there's actually limited capacity for us to do much service development. And because it's a model that's actually based on one half-time rheumatologist in a district, I do worry a little bit what should happen if I went under a bus in terms of sustainability, or just got tired. So, what about system-level integration? Well, Don Berwick has written quite a lot about this, and basically the premise here is that if we want to improve healthcare, we don't need siloed professionals working better at what they do and developing technologies. What we need is better links, and the interactions and the relationships are really what matter. And so this is a little cartoon of the New Zealand health and disability system. And the only takeaway message from here is that it's complex. And Andrew's already mentioned the phrase of complex adaptive system. And the only thing you need to know about complex adaptive systems is that you cannot seek to control them. You can only seek to understand them and manage the chaos at the margins. And part of that is this program for quality improvement and system integration called System Level Measures Framework, which I don't suppose anyone in this room has heard of. But the purpose of the program is to get the different parts of the health system working together using some high-level quality improvement measures, and here they are. So in the interest of time, I won't run through them in detail, but they basically cover children, neonates, maternity, acute demand, good management of chronic health conditions, screening, and early intervention for preventable diseases, and also a focus on youth. And this program has a number of underlying philosophies which are somewhat challenging to conventional ways in which our Ministry of Health, at least, has dealt with the health sector. So the first is that it's a quality improvement framework. It's not a measurement framework. It's designed to support districts' health board to work together with their local health partners using an alliancing approach to improve health outcomes for people and to provide a stimulus for integration of services and health systems so that people moving through the system experience integrated care. So one of the other things that Don Berwick said was that integrated care has not happened until people experience it. There's a very clear focus on health equity, particularly for Māori and other groups that experience disparity. We also have a clear intent to build capacity and capability for doing improvement work in the sector. And I was interested to see that some people that in Australia, you're still thinking about pay for performance to a certain extent or giving financial incentives towards doing things. We're really trying to move away from those ideas which tend to produce perverse incentives and unintended consequences, and instead to tap into clinicians' intrinsic motivation to do the right thing. So here's the concept. The concept is that the system-level measures are like the big dots of quality improvement. And so here's an example, acute hospital bed days, which is an indicator of acute demand, but has quite a lot to do with what goes on in the community as well. And so then around it, we've got little dots, which are contributory measures, which are things like length of stay, acuity, readmission rates, and so on. The next thing is that the ministry requires district alliances to each year produce an improvement plan. And that starts with an improvement milestone, which has to be a number. And we've used the word milestone rather than target because it depends on, for the district, what their baseline is. If you are providing services to a very disadvantaged population, as you might up in Northland in New Zealand, you are never going to be able to reach a health target. And if that's then tied to a pay-for-performance scheme, you're never going to get any funding to do any investment. Whereas if you can look at your baselines and set a milestone for improvement, and then any money that's attached is assigned to capacity and capability building, then that's a more equitable way forward. So once the district has their improvement milestone agreed, they then need to think of what they could reasonably do in the next 12 months to shift the curve. And that has to be a clinically led activity supported by management. And then the next phase is that once they've got those plans for activities, there will be contributory measures attached, which is basically how does the district know that they're making any progress and making a difference? And lastly, we require that all the different players sign up to the plan. We don't want the district health board submitting a plan on behalf of and then telling everybody else what to do. It's got to be co-designed. So now I want to talk a little bit about district alliances because these are the key to system integration and the quality improvement. And so district alliances in New Zealand are responsible for implementing the system-level measures. And it's an alliance between the district health board and the primary healthcare organization. And they vary greatly around the country in their maturity. But where we want them to go is to actually have more inclusive membership. So it's not just general practice, but it's ambulance, it's lead maternity carers, it's pharmacy, it's young child, what we call well child services, and so on. We want everybody at the table thinking about quality improvement and what we could actually do rather than talk about it. So here's an example of an improvement plan from the Hawke's Bay, which is a region of New Zealand, and I'm not going to go through it, it's just to illustrate what's in it. So we've got some analytics down the bottom about where we are, what's the time trend show us, what are the leading conditions that are, for instance, causing high ASH rates in children. Then there's a list of activities, how we're going to achieve it, what have people signed up to do, what are the contributory measures. That's what a plan looks like. And so what's the ministry's role in this? Well, the ministry has a stewardship role here, and it's a supportive one. So we're trying to move away from the old health targets approach where, the minister tells you what you've got to do, towards going to say to people, what are the problems in your district? How do you think you best can fix them? What are you going to commit to doing? And how can we help? And so what we want is to develop those relationships and better sort of behavior and getting out of those silos, which you cannot mandate, you can't legislate for that. You can only create the conditions in which that collaboration and those relationships can flourish, and that's the ministry's responsibility partly. We also have quite a big role in making sure that the measures are, have integrity. So that's about curating a library where you can go and look at the measures with their definitions and so on. And then very importantly, the ministry has a job to do in providing identifiable patient-level data back to practice level to use in quality improvement, and that's been quite an achievement. We also support our Health Quality and Safety Commission in some of their work, and in particular, their development and administration of our 2 patient experience surveys. One is our hospital survey, and one is in primary care. So, I'm nearly finished. What have we achieved? Well, we've been running this program for 3 years, and I can tell you the first year, our intention was to get 20 plans. We had, because rheumatologists, as my chairman will tell you, are patient and persistent. And we have to be. And so that was a fairly low expectation, but we did get 20 plans, but now we're sort of raising the bar a little bit. The first thing is, you mustn't expect the headline measures to change because they're very high level. There's lots of things that contribute to something like ASH rates in children. And so you need to look at the success of this program in other ways. And so the first one is that we've engaged frontline health professionals to lead quality improvement. And we've taken that away from a management responsibility. We've given district alliances something to do. We've given them a purpose about creating a shared common vision of what they want for their local system. And we've succeeded in broadening the membership of alliances. And there have been some good examples of how district health boards and PHOs have worked together. And stunningly, the 3 Auckland DHBs and the 7 PHOs came together to produce one plan for Metro Auckland. They've never collaborated on anything before. So we think that's a major achievement. And it's been done with the consent, obviously, and the engagement of the health sector. I've mentioned the patient identifiable data. We've improved data integrity greatly because there's nothing quite like putting a measure into an improvement framework for people to suddenly say, oh, what you don't understand about that measure is blah, blah, blah. And so we've had to do quite a lot of work in that. We've developed a new measure for youth health, which is a composite. And we've also provided a framework for addressing equity. So although we don't make any great claims that this framework is going to fix the problem of health equity, it is certainly a tool that has great potential to do so. So what do we observe 3 years on from this somewhat innovative program? The first is that the sole focus of the health system remains on financial accountability and performance measures. The second is that a lot of the conversations that are happening are still focused on providers and professions rather than on patients and what they need. And there's still a lack of focus on relationships and interactions and behaviors. And as I've mentioned, the capacity and the capability for doing this work varies hugely across the country, and we need to do more work to understand what drives that. There's a lot of variability in the maturity of alliances, in how engaged local clinicians are, and how well engaged patients and communities are. And as we've heard several times during this conference, there's a lack of investment in broader primary healthcare beyond general practice. And we also observe a challenge in sustaining relationships and bringing new partners into alliances. So we've still got quite a lot of work in progress. So this is my summary slide. Integrated care has different meanings to different people and operates at different levels. I believe that putting patients at the center of care requires the health system to be more integrated, and that is actually the way in which you break down health professionals in those silos having arguments about what we should do, is you say, well, hang on a minute, if we want the best for this patient, then people start to get to agreement. And that health system integration is going to require some transformational change. Thank you very much.